We're going to kick off with the Honourable Peter Dunne, Member of Parliament for the impregnable seat of Oharu, Belmont. Still good odds on I Predict, I notice. You can still make money out of Peter, who's a shoo-in at the election. And Peter, of course, is Associate Health Minister. He's been involved with the Alcoholic Liquor Advisory Council in the old days as well, and has a keen interest in the area. So, ladies and gentlemen, our first speaker for the day, the Honourable Peter Dunne.
E ngā mana, e ngā rea, e ngā iwi, e ngā rangatira mā, tēnā koutou, tēnā koutou, tēnā koutou katoa. Good morning, everybody. It's a great privilege and a pleasure to be here. It's a particular delight to link up with one of my old, I was going to say sparring partners from university politics days, but certainly old colleagues and friends, Jim Mora. And Jim, lovely to see you here. We've I guess, coincided on and off over the years, but it's great to be sitting next to you in the flesh and seeing that you've aged as well as I have. Can I also welcome Dr. Tom McClellan from the United States, who we're going to hear from very shortly, from our other distinguished visitors and contributors to this symposium. And I want at the beginning to congratulate the Drug Foundation for organising this important event. One of the things that Jim just touched on is certainly true for me in my daily work as a minister and a member of Parliament. Like him on radio, I get to meet all sorts of people. People who have a variety of backgrounds and circumstances. People who struggle in various ways. Individuals and families whose lives have been directly or indirectly affected by alcohol and drugs, and who generally are trying to make do. But even after all these years, it's not hard to be staggered by the harm that you see someone's drinking or drug abuse inflicting, not only on themselves, but on those nearest to them, and even at times on innocent bystanders. When one looks at a mass of people living their daily lives, it's sobering in more ways than one to realise that just beyond that veneer often lies a very serious range of problems. So we need to convince people that no, they cannot just manage their alcohol or drug abuse by themselves, that it will not simply go away with time, but yes, it does need dealing with, and it's not something that can just be swept under the carpet because no one will notice. So an obvious message through all of this has to be that people need to seek help at an early stage, but also that that help must be immediately available to them when they do. We've all come across cases, I'm sure, where people made that cry for help and felt that one way or another it was either ignored or rebuffed, and that sent them into the downward spiral, often from which there is no escape. So in this regard, I noted the recent comments that the Drug Foundation and the Society on Alcohol and Drug Dependence made last week, and I'm quoting, "We have a flawed understanding of how addiction works and how best to treat it. As a result, we're reaching only a fraction of the people we should." I agree with those concerns. One size does not fit all, and the treatment or the help that we provide will often have to take many different forms. It might be a talk with a trusted friend or a family advisor, or a confidential chat over the alcohol drug helpline or through accessing the Drug Help website. It might be through a community group such as Alcoholics Anonymous, or through a discussion with a general practitioner, or through a more specialised alcohol and drug counsellor or a treatment program. One size does not fit all. But there is a reality we have to focus on, and that is that one person's problem equally is not isolated to that one person. Typically, one person's problem affects at least 4 other people. And that persuades me that investment in treatment is especially worthwhile because that not only benefits those 4 or 5 people, but it also is of value to the addicted person themselves. And I think in terms of a contribution to the community, that's an important way forward. But too often, we duck the hard questions of what treatment services ought to be provided because of doubts that some have raised about whether treatment really works. And all of you who are practitioners in the field will know full well what I'm referring to. The endless argument about whether this program is beneficial or that program is beneficial, whether this investment is worthwhile or that is worthwhile, or whether the whole problem is too insuperable to contemplate a realistic response to. From my perspective, prevention and treatment lie on the same continuum. While preventing problems from arising is almost always the preferable option, it's not always the most realistic option, and we therefore need good treatment networks to assist those people who require them. Earlier this year, I had the privilege of representing New Zealand at the 54th session of the Commission on Narcotic Drugs, sponsored by the United Nations in Vienna. And the New Zealand delegation to that convention meeting hosted a side event on tackling methamphetamine, the action plan, the New Zealand experience of addressing methamphetamine. This event showcased the strategies that are being applied using a cross-government approach, customs, justice, health and police, and the outcomes that we've identified to date. What struck me were 2 things arising from that presentation. First, a number of the people from other delegations were extremely supportive of New Zealand's approach to including a strong emphasis on treatment as part of the overall methamphetamine strategy. We were commended as a nation by many for a well-balanced approach that was tough on crime but was prepared to improve access to treatment for those who needed it. The second thing that struck me was the amazement of many other countries that we were in fact in our country able to achieve a coordinated response. The number of people afterwards who said to me, "How did you get customs, police and health working together on this issue? How did you achieve that cooperation?" It was actually a very difficult question to answer because it's the New Zealand way. We do that. But it was sobering to learn that in other jurisdictions, those boundary differences often prevent coordinated action from taking place. I think that the joint agency approach we have adopted in this country and focusing on all key pillars of the national drug policy, the limitation of availability, the reduction of demand and problem limitation including treatment, is now proven to be an effective model that we ought to be using not only for methamphetamine but for other drugs as well. And I'm very keen to build on the opportunities to improve collaboration between health and other government agencies, particularly where those other agencies have programs to improve and protect community outcomes where alcohol and other drugs are undermining those communities. And my ministerial colleague, the Honourable Dr. Jonathan Coleman, is currently working to develop a high-quality addiction treatment system. And the work that's now underway includes a new mental health and addiction service development plan, the refreshing of the mental health and addiction blueprint resourcing model that was originally developed way back in 1998, and a mental health and addiction workforce review. I'm also mindful of the call from the Law Commission that this country needs an alcohol and drug treatment strategy. It seems to me that a national service development plan is essential to provide guidance to decision makers on the relative priorities and arrangements that need to be put in place to provide effective treatment and assistance to those who are concerned about their own or someone else's alcohol and drug abuse. One issue that's of particular concern to me is that we work to reduce any variance in the quality of treatment and services across our district health boards and various NGO providers, particularly when people move to another area. But that immediately raises this question. For a relatively small country, can we afford too many different local models of care? How do we ensure the best mix of services at a local, regional and national level? I'm interested in value for money, and earlier this year I was delighted actually to receive a report prepared for the Ministry of Health on the value for money we get from our problem gambling services. That report highlighted some of the key strengths of those services that I think we should look to see translated across the whole addiction treatment centre. The relevant strengths included the combination of a preventive approach alongside innovative and other well-designed intervention services, national coverage and services targeted to ethnic groups at the most risk of harm, awareness campaigns that achieve good levels of recall of the key messages, a comprehensive data set of service usage, an industry levy that recognises the industry taking responsibility, good relations between the funders, either the Ministry of Health or the district health boards, and service providers, reasonable administration costs, good levels of client satisfaction with intervention services, and overall improved value for money. Some of these considerations will also be picked up in the work that the Mental Health Commission is undertaking on the revised blueprint that I referred to a moment or two ago. I think that overall the blueprint plan has worked well, but it is probably not kept up with other changes occurring in the health sector. So future-proofing strategic documents to ensure that they have the flexibility to take account of changing circumstances, and particularly in the health sector, changing structural arrangements, is critically important, but it's very difficult to achieve. In this context, I'm mindful of the changes now proposed for the people at the Mental Health Commission, the Health Sponsorship Council, and also the Alcohol Advisory Council. And I want to take this opportunity to express my appreciation of the work that organisations like ALAC have done over the years to promote awareness of alcohol as an issue and to reduce its harm. I've been associated with ALAC since 1978 in a various set of guises over a long period of time, and I've seen the organisation grow and develop. I've seen its credibility equally grow and develop. From the time when it was seen as a very curious little group, wondering often what it was about and not really striking a chord with the public, to be now a reputable, responsible, highly regarded organisation and agency. And I think that the transition into the new role builds on that strength and ensures that the success that ALAC has had thus far in its field can be replicated across a wider field of endeavour, and I look forward to working with you in that as well. Often I hear the comment that this is all very well. Whatever we do by way of plans or strategies or provision of services is utterly dependent on the motivation of people to seek treatment. And I think that's true to some extent. But my view is that all too often that only occurs when there's sufficient pressure from family, from an employer, or quite often, frankly, unfortunately, through the justice system, that they do so. I do not think that a lack of motivation excuses professional staff from seeking to engage people in treatment. There are appropriate techniques and training available to clinicians to increase personal motivation, and I think there's a large responsibility on the professional as well as the client to engage and to increase that level of motivation to address the problem that they are suffering. I'm also aware that there are those people at the very hard end of the spectrum for whom everything else has been tried, but for whatever reason, they simply fail to engage in treatment. And they will always be a challenge for us. For its part, the government is well aware that the Alcoholism and Drug Addiction Act 1966 is aged and not working well for individuals or their families to get them the help they need. And I recall in my ALAC days in 1983 chairing a working party to review the Alcoholism and Drug Addiction Act. I'm delighted that now, as the Minister responsible, all those years later, I'm on the verge of bringing a revised act to Parliament, and that will certainly be long overdue in terms of updating a very tired and aged piece of legislation. The new bill will improve access to treatment and the likely outcomes for those people with severe alcoholism and drug addiction. It will include a rigorous framework to protect an individual's rights while they're undergoing compulsory treatment. Compulsory treatment will be a last resort option for severely addicted substance users who are chronically unwell, incapable of helping themselves, and who require life-saving intervention. Without such intervention, these people are likely to become progressively worse and require increasingly intensive health and social services. With intervention, many will improve significantly, and with good aftercare and support, are likely to enjoy a much improved quality of life. I'm mindful of a number of discussions with constituents, and I see my parliamentary colleague Ian Lees-Galloway in the front row, and I'm sure he will have had a similar experience, where family and friends, usually family, are so frustrated with someone's addiction problem and the current inability to get that person into a treatment regime. And one of the things the new legislation will address will be to make that transition so much easier, so that both the person's intransigence, that I don't have a problem, there's nothing for me to worry about, and the family's despair can be matched together and dealt with more quickly. As I say, implementing the legislation, however, is going to require some careful thought. Not the least of that will be around identifying the best configuration of services to deliver the outcomes that we're seeking. For those people who have serious alcoholism and drug addiction issues, but who do not qualify under the strict threshold for compulsory treatment, we will need to ensure that they and their families are not turned away without help. How our services have been funded in the past has concentrated on that 3% of the population with the most severe mental health and addiction needs. I would expect that in the future we would give consideration to assessing to whether we have a funding plan beyond the 3% and to what extent we're prepared to deal with moderate to severe cases. An increasing capacity may well depend, therefore, on increasing funding, but we should also be looking at some other issues, such as service configuration, the role of technology, and research and planning into not just today's problems, but also attempting to forecast our future needs. I said at the beginning that I meet all sorts of people in this job. Often it's those who are adversely affected. At a meeting like today's, it's people who are trying to address the problem. And I think it's worth noting that the people who work in this field are extremely committed and dedicated and often overlooked. Another group of people that I meet are those who actually contribute to the problem. It's a matter of public record, which I'm quite proud of, that I am not sorry to see people associated with pushing synthetic cannabis quitting that industry. The recent issues that we faced in limiting the availability of chronic and other cannabis-type products reinforce the need for effective legislation. Though both the immediate actions we have taken through the establishment of temporary drug class notices and the clear indication we are giving that effective legislation will be in place, that ultimately the government will back the Law Commission's recommendation to shift the onus of proof to manufacturers and suppliers to prove their synthetic drugs are not harmful. That is really the key approach from here. So let me sum up. My view is that if we are to reduce the harm from alcohol and other drugs, a series of components need to be in place. We need a plan for the future development of addiction treatment services, a funding stream that's flexible enough to match future needs, and legislation that's responsive to limiting the availability of harmful substances and assisting those people most affected by alcohol and drugs into treatment. All of these need to be underpinned by a workforce that is well trained and capable to deliver the treatment for individuals and the support of families that they need. They are the challenges ahead. I wish you well for your deliberations today. I look forward to working with you as we seek to put the outcomes of today's deliberations and the challenges that I've posed into place. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa.